Morning or good afternoon, everyone. This is Kelly from Visonic Medical. I'm international sales representative in charge of Turkey market. So today is our 17th the Lion College webinar series. And today is really honor for us to have Dr. Tolga and Dr. Othman to be our speaker and moderator today. So first, I would like to walk you through the whole process of our webinar today. So first, I'm going to introduce Dr. Othman, and Dr. Othman is going to give a brief introduction of Dr. Tolga. Then we will have Dr. Tolga's speech for 40 minutes. And during 40 minutes, all the audiences are allowed to ask any questions you want. And Dr. Tolga will answer your questions after the speech. So without further ado, let's welcome Dr. Othman. So Dr. Othman was graduated from College of Medicine at University of Baghdad in 1999, and he has been the Fellow of Iraq Board for Medical Specializations Anesthesia since 2006, and he worked as cardiac anesthetist in Erbil Cardiac Center from 2007 to 2020, and become the head of cardiac anesthesia department since 2011. And he has been the head of anesthesia and pain unit at College of Medicine, Harvard Medical Universities since 2014. And he has been a consultant in the Ministry of Health of Iraq since 2017. And he was the fellow of the Interventional Pain Management, Daradia Pain Hospital, India in 2018. And he was the fellowship in MIS Minimally Invasive Spine Scope from Max Super Specialty Hospitals, Dehradun, India in 2019. Sorry for my pronunciation in some words because I'm not expert in Indian or other languages.
Daradia Pain Hospital.
Okay, thank you. And he attended many international trainings on ultrasound-guided regional anesthesia and pain interventions in France, Turkey, and Egypt, and etc. So right now, let's welcome Dr. Othman.
Thank you very much, Kelly, for this nice introduction. And welcome to the audiences today. We have a new webinar within the chain of Visonic Global Webinars. We will listen to the Professor Tolga Ergonenc from Turkey to introduce for us the most innovative issues in the pain management with ultrasound. Let me share the screen now to introduce our professor. Professor Tolga Ergonenc. He is an associate professor of anesthesiology and intensive care unit, working on ultrasound guided interventions and musculoskeletal sonography. He studied Faculty of Medicine at Uludağ University, Turkey, and was awarded as medical doctor when graduated in 2000. In 2006, he joined Sakarya University Education and Research Hospital as a specialist at Anesthesia and Intensive Care Department. In 2007, he founded Korojut Campus Intensive Care Unit of SUERH. He is the founder and head of Atliazi Pain Center since 2014. He has been invited to many international pain cadaver workshops on ultrasound-guided interventions and also delivered several lectures on the international conferences. He is also a member of many professional organizations like Turkish Society of Anesthesiology and Reanimation, European Society of Anesthesiology, European Society of Regional Anesthesia and Pain Therapy, Turkish Multidisciplinary Ultrasound Society, and Morphological Madrid Research Center. So let us welcome to the professor and the speaker for you, Professor.
Thank you so much, Dr. Othman, for this nice presentation. I would like to thank to Visonic and Kelly for the nice invitation as well. And let me share my screen first. Okay. You see my screen now?
Yes.
Okay. Hello again and welcome to the Westonic Zoom webinar section of the knee joint. The next 1 hour, I will be talking about the knee joint, how to begin a routine examination with the ultrasound. And I want to do a quick short live demo. In this presentation, positioning, anatomical illustration, and ultrasound image of common skin and knee structures. I have nothing to disclose or financial interest about this presentation. In this presentation, I use a complete anatomy platform, which copyright held by 3D for medical Ltd from Elsevier. I have an educational license for this platform. I hope you enjoy and you can use this knowledge in your daily practice. If we talk about the knee joint, we need to know there is 4 different compartments with examining ultrasonography. Anterior compartment, posterior compartment, lateral, and medial compartment. Some authors say that window would like to prefer compartment. It's not important. And for the knee joint examination of the ultrasonography, it would be best to begin by talking about anatomy and sonoanatomy. You know, sonoanatomy is totally different than classical anatomy. And we need to know what is the difference. And another important issue when examining knee joint with ultrasonography, the patient position. During the patient position of the examining of the knee joint, it's very important for the best view of the sonogram. And patient should which compartment of the knee you are examining. I say that there's 4 different compartments: anterior, posterior, medial, and lateral. For imagining anterior compartment, the patient should be lie spine position, and I'm always prefer putting under the knee little pillow for the mild knee flexion. 20 degrees is enough. And the medial and the lateral compartment, we can use same position, but for the medial compartment, the femur should be a little bit external rotated, and the lateral compartment, the femur should be mild internal rotation. So let's start with anterior compartment. When you use your transducer like this is a longitudinal axis. This is a superior view and the lateral view. What are we gonna see at the sonogram? This is the suprapatellar area. This is the infrapatellar area. When you put your transducer like this, suprapatellar area, as a longitudinally, we can see clearly this image on your ultrasound device. This is superior pole of the patella. This is a femur, and this is an acoustic shadow of the femur. And the most important anatomic structure you can see clearly, quadriceps tendon. This is a quadriceps tendon. This is a fat pad. And other important anatomic structure is here, suprapatellar recess. Why it's important? Because suprapatellar recess is connected with interarticular area. If we want to do interarticular injection of the hip, your target should be here. When you reach here, you can inject local anesthetic agents, or whatever you want. This is interarticular area because it's connected with interarticular area of the knee. When you put your transducer at the suprapatellar area like this is a short axis view. What are we gonna see? We can see separate four muscles. I would like to say to you, you have to imagine your transducer like a knife. Because of your ultrasound beams are cut into tissue. So this transducer, this knife, cutting this tissue like a knife, and we can see this axial view exactly. This is vastus medialis, vastus medialis, vastus lateralis, vastus lateralis, and the rectus femoris. This is rectus femoris. This is our sonogram of the suprapatellar area, at the suprapatellar area. Vastus lateralis, vastus lateralis. This is vastus medialis, vastus medialis, vastus intermedius, and this is vastus intermedius. And you can see clearly this muscle. When you move your transducer to the distally, to infrapatellar area, like this is a longitudinal view of the infrapatellar area. What are we gonna see? Our sonogram like this. This is inferior pool of the patella. This is a patellar tendon, and this is a tibia. Tibia, patellar tendon, the inferior pool of patella, patellar tendon, and this is a patellar tendon. And there is a Hoffa pad. You can see clearly. When the knee flex maximum, we can see other anatomic structures. This is a medial condyle, lateral condyle of the femur, medial condyle, lateral condyle, and this is a perfect shape of the cartilage of the femur. Perfect shape of the cartilage of the femur. This is a quadriceps tendon. You can see clearly at this position. I want to talk about pathologic sonogram about the hip knee joint. Right side, completely normal sonogram of the suprapatellar area. But the left side, there is some problem. You can see the quadriceps tendon, patella, but there is a lot of effusion at the suprapatellar recess. There is no effusion here, but you can see clearly When the intra-articular liquid increase, you can see clearly this fluid at suprapatellar recess. You can aspirate from this side. You can inject to here some local anesthetic or steroid agent. I would like to prefer reach the suprapatellar recess, short axis, and in plane approach. This is normal suprapatellar sonogram. This is a long axis view, but there is a big problem here. The quadriceps tendon interrupted something. This is a quadriceps tear. We can see at the sonogram like this. And other tendon tear, this is the inferior pole of the patella. This is a patellar tendon, and there is some other interaction here. There is total patellar tendon tear here. Okay, there is another pathology at this site. It's very common. Prepatellar bursitis. Where is the prepatellar bursa? Prepatellar bursa is just under the skin. This is a prepatellar bursa. This is an infrapatellar bursa. It's very close to the skin. You can see clearly bursitis. And you can use a power Doppler for imagination of this area for the bursitis. When you aspirate this fluid, you can reach this area, the lateral to medial or medial to lateral side, in plane axis, in plane approach, short axis. Let's get lateral compartment. When you put your sorry. Okay. What we can see? Oh, there is a lovely lateral ligament. Lateral collateral ligament. It's very important anatomic structure. Lateral collateral ligament. And you can see lateral meniscus as well. This is a femur, tibia, and the lateral meniscus. At the lateral, when you move your transducer anterior inferior side, you can see another anatomic structure, and this is an iliotibial tract. You can see clearly at the sonogram iliotibial tract. This is a lateral collateral ligament. This is a lateral meniscus and the iliotibial tract. At the medial compartment, this is a long axis view. We can see some other anatomic structure. This is a medial collateral ligament. Medial collateral ligament, and there is a perfect V shape of the medial meniscus. This is a medial meniscus, perfect V shape of the medial meniscus. Femur, tibia, medial collateral ligament. And when you move your transducer anterior inferior side, we can see other anatomic structure. We call that pes anterior tendon. There is 3 separate muscles. This is sartorius, semitendinosus, and gracilis. 1, 2, 3. And there is a medial collateral ligament. You can see clearly this image attached to the tibia. At the posterior compartment, a short axis view at the medial side, what we can see, we can see some muscles at this side. This is the axial view. This is a semimembranosus, this muscle. This is a semitendinosus, this muscle. And this is a medial head of the gastrocnemius. Medial head of the gastrocnemius. We can see clearly. And there is most important area at the posterior side of the knee. This area. What's this? We can see some cysts here. The cyst origin from here. Baker cyst origins from here. When you look to 3 muscles area, we can see sometimes Baker cyst. When you move your transducer to the medially, you can see some vascular structures. This is a popliteal artery, popliteal vein, popliteal artery, popliteal vein, and you can see tibial nerve. This is a tibial nerve as well. This is a common fibular nerve. Okay, most famous nerves at the knee joint, genicular nerves. Genicular nerves are travel with the genicular artery. When you see the genicular artery with your ultrasound, you need to know there is a genicular nerve behind or very close to the artery. This is superior lateral genicular artery, superior medial genicular artery with superior medial genicular nerve. There is superior lateral genicular nerve as well, and inferior medial genicular artery and nerve, and there is inferior lateral genicular nerve as well. But we need to know 3 of them because of 3 of them, superior medial, superior lateral, and inferior medial. That's enough for us because the pain palliation of the knee joint. When we would like to perform diagnostic block of the genicular nerve, you can block these 3 nerves, and if the pain palliation was done, we can perform second step, radiofrequency ablation of the genicular nerves. This is my patient. I'm looking for the genicular nerve, long axis view. Yes, you can see the pulsation of the genicular nerve. You can see clearly. This is a long axis view. When you turn your transducer 90 degrees, the short axis view, you can see the genicular nerves, genicular artery like this. I usually prefer to blocking these nerves in plane approach with a short axis. My needle comes through to the lateral to medial side, very close to genicular artery, and I usually prefer very small amount of local anesthetic agent for the diagnostic block. The most common compartment pathologies are these slides. And these are my references. And I would like to thank you. I would like to thank you for all of you for your patience. And the last thing, I would like to inform you that MOMARC is the Morphological Madrid Research Center, was founded as a branch of ultradissection. The MOMARC is a modern contemporary research center located in Madrid, Spain, and has collaboration with all over the world. If you would like to research about pain medicine or regional anesthesia, or would like to be a fellowship, you can connect with us. And thank you so much. Thank you so much for listening to me.
Thank you very much, Professor Tolga, for this informative presentation. And we can go now to the questions. We have a question from Dr. Ahmed Shakir. First, greeting you, and wonder how to distinguish tendons and ligaments under ultrasound. You want to know how to distinguish between ligaments and tendons under ultrasound? Because their images sometimes look the same.
Yes, I agree with you. Sometimes they're very look the same, but we know that very good sonoanatomy. Sonoanatomy is most important thing in our daily practice. So if you make lots of practice, because of practice makes better, you can understand all the anatomic structures under the ultrasonographic image. We need to follow. When we find something and we don't know what is this, we need to follow. Is it nerve or is it vascular structure or ligament or tendon? We need to follow, trace it, and you can understand what is this anatomic structure.
Yes, sure. You mean we can also start from the muscle and go with it until we reach this tendon, so that we can realize the tendons from the ligaments over there?
Yes, exactly.
Yes. And the second question from the same doctor, asking for tendon tears if they are accompanied by inflammation, how to make diagnosis if there's a tendon tear with inflammation?
Yeah, you can use a power Doppler. our imaging show to us, is there an inflammation or not?
Okay, yes.
And you can use elastogram as well.
Yes, sure. There's another question from Dr. Emidros asking the significance of color mode scanning for Baker cyst.
Sorry?
Asking for the significance of color mode scanning in Baker cyst.
What kind of significance?
Color mode scan.
Color mode.
Yes, color mode scan in Baker cyst.
When we think about the Baker cyst in sonogram, we have to need color Doppler, because sometimes cysts look like vascular structures look like cysts, especially posterior side of the knee. Sometimes the tendons are very similar looking to the Baker's cyst, but there is a very big differences. When you move your transducer, anisotropy occur at the ligament or other structure, but not the Baker cyst. And you can see perfectly powered Doppler image with a vascular structure, but not Baker cyst.
Yes.
Yes.
Another question from Dr. Carmen asking for saying, considering the complex distribution of nerves in the knee joint, what nerve block can you can plan to provide good analgesic effect for knee surgery?
For knee surgery, or after the knee surgery for postoperative pain palliation? Which?
No, I think the question only for what nerve block plan can provide good analgesic effect for knee surgery.
For knee surgery, okay. We would like to prefer in our country, especially in neuroaxial block for the knee surgery, but you can perform first compartment block and the sighted block, and you can perform all the surgery of the lower extremity. But if he or she asks chronic pain management, especially Caligran 4 or Caligran 3, and the patient don't want to go to surgery, or after surgery, after total knee replacement surgery, the pain sometimes persists. So we can make the chance for the radiofrequency ablation of the genicular nerve to patient. So the 3 nerve is enough for the genicular nerve ablation, supermedial, superlateral, and infrapatellar. This is just chronic pain palliation.
Yes. We have another question from Dr. Nels asking about the benefit that ultrasound can provide in the treatment of post-op knee joint pain relief.
He asked to me what is the benefit of the postoperative pain palliation of the knee?
For post-knee replacement pain relief.
Okay. There is two separate times: the acute postoperative time and chronic postoperative time. Sometimes the knee replacement doesn't perform to pain palliation for some patients. So the doctors, colleagues, and the patients are very depressed for the situation. When the diagnostic block work, which three nerves, superior medial, superior lateral, and inferior medial, we can use this ultrasonographic guidance. So as well, so we can use the CR fluoroscopic guidance as well, but sometimes combining the fluoroscopy and ultrasonographic guidance for the better result. But we can see the clearly superior medial, superior lateral, and inferior medial genicular artery with ultrasonography. Sometimes we cannot see, so maybe the patient has a very high body mass index. We need to combine with CR fluoroscopy for the anatomic landmark. But when we talk about genicular nerve ablation, the ultrasonography is superior than CR fluoroscopy.
Yes, sure. Okay, we have another question from Dr. Jacques Ruin, asking about the usual treatment for prepatellar bursitis by ultrasound.
Okay, prepatellar bursitis, when the prepatellar bursitis occur, the first step is diagnosis. You can diagnose with ultrasonography perfectly, and you can aspirate and inject into the bursa local anesthetic agent with steroids. I usually prefer intrabursal injection, some corticosteroid agent with a high molecular, high weight molecular steroid agent, particular steroid agent. Intraarticular, I prefer low molecular agent, but intrabursa high molecular agent is better than other.
Yes. Okay, we have another question from Dr. Mayank, asking about, is the degenerative change of the knee joint visible under ultrasound? Are there any obvious ultrasound symptoms? What treatment you recommend?
Okay. The osteoarthritis of the knee joint, diagnosis of the osteoarthritis of the knee joint, the ultrasonography is not gold standard now, but you can see some anatomic changes with ultrasonography. You can see the cortical destruction. You can see the osteophytes. You can see the spur, and you can see the cortical irregularity with ultrasonography. All of these show to us there is some osteoarthritis. We know that there's 4 grades, Calagron Lawrence 4 grades at the knee joint and other joints staging. If the first or second stage of the Calagron Lawrence, I usually prefer use the intraarticular ozone therapy. Yes, PRP a good choice as well, but in my country, the PRP is not covered by social security, social insurance. So we can use intraarticular ozone for the Calagron Lawrence 1 or 2. 3 or 4 is not good as good result with PRP and ozone therapy as 1 or 2. So 3 and 4 grade of the Calagron Lawrence should be considered for the surgery if the patient not young. If the young patients or postoperative pain occur, pain persists, we can consider to genicular nerve ablation. Thank you.
Okay. There's another question from Dr. Alex. What are the kinds of ultrasound images of knee synovitis? And thank you, Professor.
What kind of?
Ultrasound of knee synovitis.
Okay. The first, you can see the loss of fluid, effusion, and some synovial particular swimming in this fluid. You can see clearly, and you can open your power Doppler. You can see inflammation clue at that time.
Okay. We have another question from Dr. Khalil Karim asking about if a patient with the OA changes grade 4 and need to do pain management with hydrodissection for the nerve before radiofrequency ablation. Which method you prefer? He meant that with the hydrodissection for the entrapped nerves before going to the radiofrequency ablation of the genicular nerves.
Okay. Hydrodissection of the genicular nerve is not easy because we cannot see clearly the genicular nerves under ultrasonography. So I think he asked to me before the genicular radiofrequency ablation, I'm always prefer the diagnostic block. If the diagnostic block works, I choose a radiofrequency ablation. Once upon a time, I was preferring conventional radiofrequency ablation, but for a long time, I prefer to pulse RF because of pulse RF doesn't harmful effect on nerve, and there is no neuritis side effect. There is no refractor pain side effect, and the pulse radiofrequency is very suitable for the genicular nerve and its work. I have some paper, if you want, I can send to you about the genicular nerve pulse radiofrequency. Thank you.
Yes. We have a question from one of the audiences. His name is not registered, without name. Which nerve blocks can be used for knee arthroscopy?
Knee arthroscopy, especially in my daily practice, my colleagues who are anesthesiologists, they prefer neuroaxial blocks, spinal anesthesia.
Okay.
If you ask postoperative analgesia, you can perform some perfect nerve block, but we not need always.
Yes. There's another question from the Torniers about the benefit of the ultrasound can provided in the treatment for post-op knee joint pain relief.
Sorry, what he can want to ask exactly?
The benefit of the ultrasound can provided in the treatment of post-operative knee joint pain relief. I think we did answer.
Yeah, we did it. We answered the question. Yeah. Okay.
Yes. Here's another question from Dr. Alex saying, how do you think the butterfly or Philips Lumify helps in regional anesthesia? Are they really useful? Doctors will choose that or not, and why? Thank you.
I think that the ultra portable device are gonna be smaller and smarter. We need to ultra portable device for the interventional procedure and diagnosis nowadays, especially nowadays, because of they are very easy to care. They are very easy to sterilize. The big machines are not exactly. I don't want to say some brand mark which is better than other. All of the devices are very, very good, but we know that they will now in this technology, they are never as good as conventional ultrasound device, but they are very useful.
Yes, sure. Okay, here's another question from Dr. Khalil. Would you prefer to inject PRP or steroid and lidocaine before radiofrequency ablation?
I say that if the Calgon levels 1 or 2, there is some chance of the PRP, ozone therapy, local anesthetic, or steroid agent. But if the Calgon levels 3 or 4 grade, and we think about the genicular nerve ablation, I believe that there are not beneficial effect on the knee pain.
I think he was meaning about the steroid with lidocaine for in the same session before you start radiofrequency ablation to abolish the effects of neuritis or something like that. I think this was the main question like this.
So we have a quick demo if you give me 1 minute, okay?
Sure.
I'm preparing now my quick demo, please.
Okay.
Do you see clearly now?
Yes.
Yeah. The position is important. I usually prefer to putting the little something like this to little flexion of the knee. Really? And I'm starting the anterior side of the knee, anterior compartment of the knee. And other important issue is the orientation of the probe. where is the left side and where is the right side. You can see clearly?
Yes, it's quite clear.
Okay. This is a patella. You can see the patella. And there is a perfect quadriceps tendon. Okay.
Yes.
And you can see the femur and the femoral fat pad. And there is a recess, suprapatellar recess, very tiny, because there is no effusion here. There is no effusion. So the prepatellar recess is very, very tiny. We can see the quadriceps tendon and the patella and the femur. Okay. This is the patella. I'm going to inferior side of the patella. Yes, you can see patellar tendon perfectly. Inferior pole of the patella. At the right side of my screen, the left side of my screen is tibia, tuberous tibia, and along with patellar tendon. You can see?
Yes.
At the axial view of the suprapatellar area, we can see the femur clearly, and we can see the quadriceps tendon. Yes, this is a beautiful quadriceps tendon. And the medial side and the lateral side. There is no effusion, there is no bursitis. At the medial side, yes, there is a lovely medial meniscus. This is a perfect V shape. You can see?
Yes.
And you can see other anatomic structure. This is a lateral collateral ligament under the skin, upper side of the medial meniscus. The lateral side of the knee, yes, we can find lateral meniscus as well. And there is a good V shape, and you can see the lateral collateral ligament. Okay. Wow, perfect cartilage. This is lateral side, lateral condyle, and other side, a medial condyle. And the middle of them, you can see quadriceps tendon. There is no osteoarthritis sign. Perfect shape of the cartilage. So we're gonna look to genicular artery. This is a femur. Yes, there is 3 vascular structure here. The 2 of them at the superior side, but one of them very near to cortex. This artery pulse? This is pulsating artery. Yes, color is coming. This is a genicular artery, medial superior genicular artery. It's very near the cortex. Do you see? Are you there? Everybody is okay?
Quite clear, yes.
Okay. This is genicular artery. Not others. Yes, others are artery, but not a genicular artery. There's another artery here. I don't think so. This is not a genicular artery.
Sure.
This is genicular artery. Okay. Thank you so much.
Thank
this
you.
is a very short demo.
Yes, very beautiful demo and very informative.
Thank
you so much, Tolga, for this demo. We'll now turn back to the questions. We have a few questions remained. One from Dr. Azmi asking, can we use regenerative procedure like PRP for treatment of chondromalacia patella?
Yes, of course. You can use therapy, also ozone therapy.
How many sessions you use it usually?
For ozone?
For the PRP or ozone?
PRP, commonly 3 times, but ozone therapy, commonly one time is necessary, maybe 2 times, but usually 1 time is okay.
Yes, thank you. We have another question also from Dr. Khalil asking about the ablation of middle genicular nerve with the other 3 genicular nerves during radiofrequency ablation for the knee joint pain.
Superior medial or superior inferior medial? Which superior or inferior? We need to block both of them, superior medial and inferior medial. Plus superior lateral.
No, sorry, he's asking about the middle.
Middle, it's not necessary. It's not necessary. It's not necessary. Yeah, there is a very complex plexus at the over of the knee joint, but we need to block just 3 nerves, not much more.
Yes.
Thank you so much.
Thank you too. I think we don't have any question left. Thank you so much for you, Professor Tolga, for this nice presentation today. And thank you for We Sonnet Love webinar series for this opportunity. Thank you for attendees. Hope to see you again next time with the new objects and issues in ultrasound and pain management. Thank you very much.
Thank you so much.
Okay, so before we left, I would like to notice all the audiences that we'll have regular webinar basically once every week. Please follow our Facebook and LinkedIn so you can see our updated information. Thank you, Dr. Tolga and Dr. Othman. Thanks again.
My pleasure.
Bye-bye.
Good afternoon. Have a good day.
Have a good day.